Assalamu alaikum, ladies and gentlemen. Good afternoon and welcome to Gets Pharma Webbit Learning Cell. As you know, overactive bladder is a condition that affects significantly the quality of life of the patient. And due to current situation of COVID-19 in Pakistan, many of the patients suffering from overactive bladder are unable to reach their doctors and get diagnosed and proper management. To address this challenge, we have with us Pakistan's one of the most renowned consultant gynecologist and obstetrics professor. She will be addressing the topic of diagnosis and management of overactive bladder in COVID-19 era using telemedicine. That is the topic. And without any further ado, I would like to introduce our keynote speaker for today's lecture. She is none other than Professor Haleema A. Hashmi. She is a consultant gynecologist and Department of Obstetrics and Gynecology, Liaquat National Hospital and Medical College, Karachi, Pakistan. So without any further ado, over to you, Professor Saiba, for the interesting topic.
Thank you very much. Assalamu alaikum. I think I'm very thankful to Gets Pharma for giving me an opportunity to talk on a very important topic in this time when the people are, majority of the patients have a very restricted movement, and then if they have any queries or any questions, so they ring their respective doctors, family physicians, or their gynecologist to find out what is going to happen, because this is a very common problem. So before we start, I think in this time of global pandemic, when everyone is worried what is happening and how it is happening and how it is involving such a large number of people, we try to start the things with a dua or with request from we need protection from the God, from our Allah subhanahu wa ta'ala, from this particular damage which is going on because of this and for anything which happens, and we always want to have the protection with dua is a very important element of our dealings of every day, so that we can start the things. Whenever we start things, we always have to ask from our God to help us in managing all these problems, which are the worldly problems. Its main topic is bladder, and its relationship to the COVID-19. So the objectives of my talk to you will be what is overactive bladder and how common it is in our clinical practice, what factors behind the persistence of overactive bladder symptoms in spite of the treatment in women, and overactive bladder in the time of COVID, can we get a spread of COVID-19 infection through urine? How we see COVID-19 bladder. So, and the diagnosis and pathophysiology of overactive bladder, some basic things about the overactive bladder, the modifications, management of refractory OABs, and the ideal drug therapy for refractory OAB patients, as well as the clinical trials which support combination therapy over dose escalation. So we usually go to these topics one by one so that you can understand what is overactive bladder. If we know physiology, then we will be able to go further. What is overactive bladder? It is a clinical syndrome describing symptom complex of urgency with or without urgency incontinence, and is usually associated with coronavirus is spread through urine. There have been several questions now coming into the people's mind, particularly the patients and also the caregivers who are looking after those patients who have urinary incontinence. There are several studies which have shown that secretions like nasal secretions, saliva, as well as it has been isolated, a virus has been isolated in one of the channel studies from diarrhea and vomiting. So we are not very sure whether the urine is also one of the uh, one of the secretions from the human, and so it is also likely to be infected. So patients would, we know that they have to or urinate very frequently and usually without any much notice, and by the time they reach to the toilet, they already had an incontinence. So naturally, there is a lot of spoilage going on, and so the caregivers are looking after them, they are at risk through these secretions. Elderly patients with the underlying conditions are also at greater risk of contracting and because there is any previously present in the patients who are elderly, particularly over 60, 65. And this is a disease of old age varying from 40 to 60 years of age. So this can lead to more severe complications if by chance they contract or if they are infected with coronavirus. Urinary continence, how can we advise the people who are taking care? That is very important because the most important basic management of COVID-19 is the protection of those who are not infected, right? Prevention is a basic. So all over the world, people are trying to prevent infections by doing sitting at home or by lockdowns or by avoiding touching things. So main thing is that those who are looking after the patients, they have to wear the mask, they have to wear gloves, gowns, and they wash hands very frequently after they have attended such patients, and they should clean shared surfaces with sanitizers or with any antiseptic things. There has been some studies, not so much studies, it has been suggested in the studies which are published from the Wuhan, China, that the patients who have any other complication like diabetes, hypertension, or multiple therapy, they are at risk, and they can also get more fatal complications compared to those who have and the person related to the COVID-19 and the management of the overactive bladder is the drug interaction, because many drugs which these patients use, multiple drug therapy or single drug therapy, they may have some interaction, but so far it has been suggested that like chloroquine or hydroxychloroquine, which has been used in the management of these moderately severe and severe cases, has no direct drug interaction with the drugs that we use for the management of overactive bladder. You understand what happens and what leads to overactive bladder. There is a bladder filling phase, right, in which the bladder, the urine keeps on coming and collecting in it. This is in during the filling phase, the detrusor muscles and then remains contracted, and the pelvic floor muscles also remain contracted. Then in the second phase, when the patient gets the first desire to micturate, it is relaxed. All the things are, detrusor is relaxed. Then we come to the normal desire of to void. In this, the bladder contractions starts. Bladder is no longer relaxed, and then this will lead to the micturition when the bladder relaxes and the urethra contracts and the pelvic floor contracts, and this leads to bladder contracts, urethra relaxes, and pelvic floor relaxes, and then the cycle repeats again when the detrusor relax, urethra again contracts at the end of the micturition when it is completed, and the pelvic floor contracts. So this cycle goes on in every time any female micturate. What happens in cases of overactive bladder? That these three symptoms, frequency, urgency, and urgent continence, they usually overlap. The patients may have urgency, may not have urgent continence, and they still can go to the toilet and can pass urine. And it is also associated. So it's a symptom complex, and the symptoms overlap with each other. But what is the basic symptoms? Basic symptoms is urgency, which is the bladder contractibility, right? And this leads to increased frequency and reduced intravoid interval. It also leads to incontinence, it leads to nocturia. And every time the patient passes, she only passes small amounts of urine, but she gets the desire to pass more frequently. So involuntary retractions of vessels during the filling phase of the maturation cycle, mediated by acetylcholine-induced stimulation of bladder muscarinic receptors. Muscarinic receptors M2 and M3 are demonstrated to cause direct uh, uh, stimulation of bladder muscarinic receptors, and then the muscarinic receptors M2 and M3 are demonstrated to cause direct is responsible for normal maturation contract. Okay, now we come to the diagnosis. History examination is very important. The most important thing is that you have to ask the patient uh, what symptoms she is getting, right? What type of incontinence she has, what type of desire she has. And in the history, the most important thing, apart from the presenting symptoms, her past history, her obstetrical history. The incidence of overactive bladder is around 40% around the globe. In our country, the incidence has relatively decreased because of the more cesarean section deliveries and because of the reduction in the duration of the reduction in the duration of the patient's damage to the pelvic floor muscles. So that's why it's important to know the drug history. The patient is taking some sort of drugs which have a diuretic effect, and she's passing more urine because of that. And also the detailed examination, including journal and physical examination, as well as the abdominal examination to see whether there is any abdominal mass, which may be the reason of frequency, or she has a full bladder. She's not emptying it properly every time, and that's why she gets again and again desire to pass urine. The pelvic examination is must. We cannot do without it because we have to see the demonstration of the incontinence. If it is a stress incontinence, we have also to see, because it's a disease of relatively older women, the estrogen status, because the bladder as well as the genital tract, they occupy the same receptors for estrogens, and they are estrogen sensitive. So when the estrogen deficiency occurs in menopause, it will give rise to vulval excoriations, and sometimes we can see very thin vagina, which is the sign of estrogen deficiency. And also if there is any associated pathology, that can be ruled out. Then the neurological examination, because it is not necessary that the bladder frequency or overactive bladder is always due to just overactive bladder or bladder contractibility. It may be due to some other reasons. The neurological bladders also present in the same way. And so the important thing is that we should examine the cranial nerves S2, S3, and 4 outflow, so that we can rule out the multiple sclerosis and other neurological diseases. So it is not always bladder. We have to rule out stress incontinence or delays. We have to rule out stones, bladder tumors, secondary to some medical conditions like diabetes, myeloma. We have diuretic drugs for too much fluid or maybe in the evening time, and so that leads to nocturia. That is important. Important and then the invasive investigations like uroflowmetry or urodynamics. The cystoscopy or examination of the bladder is very rarely indicated when there is recurrent urinary tract infection or if there is hematuria or there is painful urination. Then we have to rule out any bladder pathology. Urinary diarrhea, I think this is the most important thing that gives us the information. What type of problem the patient has. The International Continence Society has defined the 3 types of urinary diaries, just the micturition charts in which only times of micturition, frequency, volume charts, or the bladder diaries, which records the times of micturition and voided volumes, as well as other information such as incontinence episodes. So in this time when the patients are at home, and we like to, if somebody rings you from, then she's a patient, you are a patient as a consultant or as a GP, general practitioners or family physicians. If they ask you to how should they keep the records of how much urine they are passing, then the bladder diary is very important. So you can send them on a WhatsApp the examples of the urine diary. She can keep a record of her times of micturition, she measured that, and also that she has to use the pad to keep her swelling of the clothes, and then the fluid intake, how much she's taking, and she has to do she has to go. All these things she can record and she can send back. So the telemedicine, we will be able to know what type of symptoms they are getting. Similarly, on the telephone also, you can patient can describe her symptoms, and then you can send her some charts and some things to fill up. And then after 1 week, when they have completed, you get them back, and then you can diagnose what she's doing it, and then we can and keep the this way the medicine in this case when we are can help the patients, and they can communicate with their physicians how to tackle their problems. These are different examples. Then the urodynamic investigations, when we are not sure whether it is an urge incontinence or overactive bladder, or it is a distress incontinence, in which we the treatment is the incontinence. We need to have to differentiate between the two. We have to do the urodynamic investigations, which are the detailed investigations in the form of this is the graph that shows there is any premature uterine, the premature bladder contractions. And in this particular patient, she is suffering from overactive bladder because there are 2 premature contractions that you can see here. Right? So these are the premature contractions before even she gets the desire, and then once she's allowed, she passes urine. Common therapeutic agents which have side effects, as we just discussed, whether there is any drug interaction with the treatment of COVID-19 and the treatment of overactive bladder. There are certain drugs also which may have side effects in the form of urgency and frequency and urinary incontinence. And the example is diuretics. The patients who are COVID-19 and they have pulmonary symptoms, they have to get sometimes for the treatment of overload, they may need to have the diuretic. So that may be one of the questions where the patient is not sure. Then some calcium antagonists can lead to urgency. Benzodiazepines, which you use for sedation, can also lead to secondary incontinence. Similarly, anticholinergic drugs, including antidepressants, opiates, and antipyrrhinic drugs, they can lead to urinary retention with overflow incontinence. So the incontinence symptoms may be due to some drug side effects. Now we come to the treatment. There are different types of treatment. Bladder retraining is one thing. As we said, that when the patient keep the bladder diary, they know what is the reason of and at what time they can get more frequency of micturition, of more times they have to go to the toilet. So they have to train their bladder that every 2 hours they should pass urine so that they should not get the soiling of their clothes. This is described by Jeff Scott. And by doing this, quite a lot of people do not have to go on to the treatment. Then the pelvic floor muscles, this is very important in those patients who have had bad obstetrical histories, had long prolonged labors, particularly second stage, and then they have a poor pelvic floor muscles, and that leads to also poor bladder detrusor muscles. So this is one of the management that we advise: pelvic floor exercises, Kegels exercises. A meta-analysis has concluded that bladder retraining is more useful than giving placebo treatment, and then the pelvic floor muscle training is also important. NICE and International Consultation on Incontinence also recommend that bladder retraining should be considered as the first-line treatment in all women with overactive bladder. So these are without drugs. Now we come to the drug therapy there. And the behavioral therapy is another important, how you change your lifestyle. How can we change our lifestyle? This is important. You can, particularly, the most important thing is to reduce weight. And then the other important things are that we more and drink more, and also different types of the eatables which can do, or the drinks which can lead to more free. There are different groups of the drugs which are important. Antimuscarinic drugs, which are oxybutyrin, tolterodone, and sulfenazine. They are the first line of treatments, and they have been used for a very long time for the management of the overactive bladder. Then another drug came, which is the relatively new drug, mirabegron, the selective beta-3 adrenoceptor agonists. Then the desmopressin, which is the tricyclic antidepressants. They have been used for a very long time, but do not have actually a physiological role, do not actually tackle the basic pathology of the overactive bladder. Then the estrogens, they have been tried in postmenopausal patients as to help maintain the health of the bladder, essential for normal pressure transmission. In urethra, these are the sphincter muscles, urothelium, and vascular tissues, and the urethral structures which are under the influence of estrogen. As I told you, that both urinary tract as well as the genital tract, they have the same receptors for the estrogen, and they both are affected by the estrogen deficiency or estrogen supply. Estrogen use has been promoted in postmenopausal women, but the chief mode of action is not clear, but main thing is that it improves the vaginal health and the urethral health, as well as the urethral musculature and the functions of the bladder. So it is likely to have a beneficial effect. But there are some antimuscarinic side effects: the dry mouth, dry eyes, blurred vision, dry skin, constipation. More commonly, the dry mouth and the constipation effects. It occasionally can lead to urinary retention. Then if the patient delays the passage or delays the desires, then the palpitation, in some patients, heartburn, and the headache, agitation, sometimes the tingling of the fingers or toes, or abnormal sensory sensations in the peripheral parts. Mirabegron, this is Betmica, which is a new drug, which is beta-3 adrenoceptor agonist, causing the bladder to relax, which help to fill and also store urine. Whereas the other drugs has a different mode of action. So the dose recommended is 50 milligram, 25 milligram if there is renal or hepatic impairment. The NICE guidelines suggest the importance of its use, and they have recommended it be used as a second line of the drug. An option for treating the symptoms of overactive bladder in those patients who do not respond to either antimuscarinic drugs, which are the first line of drugs, or which are or the antimuscarinic drugs are contraindicated because they are taking some other drugs, or they are ineffective, or they are not, or the patient cannot adhere to them. Patient compliance is bad because they have unacceptable side effects. Mirabegron is a first-in-class select beta-3 receptor agonist, both efficacy and side effects, including dry mouth of antimuscarinic therapy are related to the specific interaction at the muscarinic receptor, whereas the Mirabegron does not have that effect. If we see this diagram, this diagram is very much explanatory. We can see this is the parasympathetic mode and the cholinergic control. So the bladder has two types of controls. One is parasympathetic and the other is sympathetic. In parasympathetic, it is acetylcholine mediated, right? And so it has antimuscarinic effect. And what it leads to, it causes the involuntary contractions, right? Whereas if we go to the sympathetic side, if we go to the mirabegron, which is adrenergic controlling drugs, it acts through the sympathetic pathway and it increases relaxation. So actually in both the ways, when the relaxation increases, patient will not be able to hold urine for a longer period of time. On the other hand, with antimuscarinic drugs, it inhibits voluntary contractions, so it prevents the infection, but the relaxation part is more effective in the control of the overactive bladder symptoms. Now, the very important thing, these are the those who treat urogynecologists, or most of the gynecologists actually treat overactive bladder, and they come across with the patients who have refractory OB. Why we call it as a refractory OB? The refractory means that if they are not responding to the drugs which are given to them. So the gap that we like to know, where is the gap? Why they are not responding to the drugs which should act, right? Because we have already done all the investigation and we know that these drugs have a very important effect on these things. So medication adherence is one thing that we have to think about, right? So we have to ask the patient whether they are taking regularly or not. Then the other thing is the patient, it's very important that the patient should give us realistic information. Sometimes they say, yes, they are taking regularly, but they may not be taking it regularly. Then most of the gynecologists are very busy in the busy gynecology clinics or with obstetrics as well. And so they don't have time to ask the patient why, what is the reason why they are not taking it? Is it the side effects, or is it something else which is bothering her, or it's not being effective? So we need to get a detailed consultation with the patient regarding the compliance, why they are not motivated, and then how can we motivate them by our talks. Then the lifestyle modification, if we can tell them that they reduce their intakes, they have more exercises in their routines, and then the proper counseling of them, then how they are going to be benefit, how they can reduce the side effects, what are the other things that they can use apart from the drugs, which can help decreasing the dosage of the drugs. So that can be important. So there are different drugs also which has been used in the international trials. So we have to find out what is the ideal therapy option for refractory OAB. Some patients will not achieve sufficient improvement in symptoms with monotherapy or just one drug. And then there are several trials which have been conducted which shows that increasing dose will lead to adverse side effects. Incidence of dry mouth, constipation, increased blood pressure, and risk of UTI with beta-3 adrenergic agonists. So one drug caused dry mouth, the other drug may cause the risk of UTI. So recent guidelines from European Association, from American Association, and from The Canadian Urological Association recommends combination therapy with mirabegron and antimuscarinics. They both can be used together. So management of overactive bladder, apart from these two drugs, the other therapies are, if those combination drugs also fails, then we can use the botulinum toxin, which is an FDA-approved Botox injections, which are used in the bladder, and it was approved in 2013, and hundreds units are injected into the bladder wall muscle at 30 sites for overactive bladder and 200 units for neurogenic bladder. It acts by inhibiting the parasympathetic response of acetylcholine from the motor neurons and inhibits diffusal contraction. So this is one another way of treatment, right? And then if we are using Botox treatment, then we have to stop aspirin 7 days before, and we do not give nitrite to these patients, and UTI should be excluded. No acute urinary retention. Patient willing to initiate self-catheterization, then we can try this, because sometimes it can lead to retention. This is just the picture shows how we can give through the cystoscope. We inject in 330 sites, and this is helpful. The other are very rarely used, and these are percutaneous tibial nerve stimulations, but these needs hospitalization or the hospital surroundings. Sacral neuromodulation is another way, and it acts again by the parasympathetic motor neurons, but it is more invasive and requires OT facilities. So in conclusion, the evidence from clinical trials indicates that the combination of mirabegron, which is 50 milligram, and sulfenacin 5 milligram, they provides an effective and well-tolerated option in adult patients. So by the different trials, they have used the either alone or in combination, and they have also tested whether the efficiency, number of the frequency of the micturition, and then the side effects and the risk of UTI. All these measures have been tried in different combinations, and then these trials have suggested that in combination of 50 milligram mirabegron and sulfenacin provides an effective, well-tolerated option in adult patients, clinically meaningful improvements in symptoms and quality of life parameters. And so these improvements have been sustained up to 12 months when the trial was continued. The most important thing is that if the patient is 40 to 50 years of age, she's still in her working capacity and she's still working somewhere. So the quality of life is very important for these patients who are working, mainly working outside or working at home. It is important that they can have a period of freedom where they can work definitely for 2 to 3 hours, sit and work together. So I think the management of overactive bladder in this era can be another important issue which the patients may have come across, because the anxiety and anxiousness, anxiety, and the environment around you of the around is so much distressing that the patients get more and more frequency of micturition. It is a well-known fact that during the period of stress, the frequency of micturition increases. So in this distressful time when we all are suffering from some sort of anxiety, I think the incidence of urinary overactive bladder or the urinary frequency and urgency is likely to increase, and more patients will be coming to the clinics, or they may be referring to their physicians, asking about what should they do. So I think there is not a very direct relationship with COVID-19 infection, but indirectly all the diseases which coexist with COVID-19 infection are likely to have more burst effect on the improvement or the care of the patients, and also it's likely to have more fatal complications if they are using multiple drugs, or if they have associated diabetes and other problems, because in this age group we expect all these things. So I think with this note, I try to end my talk that the telemedicine and the instructions that you get can help the patients. And there are different ways of using the different social medias by which we can help our patients, even sitting at home and sitting in from our clinic, and the patient still sitting at home. She hardly have to come for the investigations. And usually we advise them not to come to the clinic for trivial symptoms. Just try the maintaining the record and try the drugs, and also not to come for extensive investigations like urodynamics or other things until the this active phase of pandemic goes away. So do not rush to the clinic. My advice to the patients is
Thank you very much, ma'am, for this very well briefed and detailed presentation. There are certain questions that people have asked, so I'll be asking you one by one. तो उसका फिर आप आंसर कर सकती हैं मैम. फर्स्ट ऑफ ऑल क्वेश्चन एक आया है कि फॉर हाउ लॉन्ग अ मेडिकेशन फॉर ओवरएक्टिव ब्लैडर डिजीज शुड बी कंटिन्यूड बाय द पेशेंट. यानी कि अगर डॉक्टर साहब ने उसको एक मेडिसिन लिख के दी है तो उसने ओवरएक्टिव ब्लैडर के लिए उसको कितना अरसे के लिए यूज करनी है. तो मैम इसका प्लीज आंसर कर दीजिएगा.
actually these medications have to be used for a longer period of time, right? Minimum is that you have to try at least 12 months to get the maximum benefit. And if you combine them with the behavioral disorders like limiting your fluid intake in the evenings, and also when you are going out, and all the other lifestyle modifications, reducing your weight, and including some exercises, general physical exercises and pelvic floor exercises. So minimum you have to try at least 12 months, and then gradually reducing the dosage may help. And as long as your symptoms persist, you can try without the drugs for a time being, but initially large doses and then reduce the doses, and minimum at least 1 year they will try.
Okay. So the answer to that question would be for at least 12 months, the medicine should be continued by the patient for optimal results. Ma'am, second question is, क्योंकि आजकल सोशल डिस्टेंसिंग प्रैक्टिस की जा रही है, तो हाउ कैन अ पेशेंट परफॉर्म कीगल एक्सरसाइजेज एट होम. क्या उसको कोई टूल्स रिक्वायर्ड होते हैं कीगल एक्सरसाइजेज के लिए, या वो घर की चीजें भी यूज कर सकते हैं, वो एक्सरसाइज कर सकते हैं. तो इसके बारे में थोड़ा सा गाइड कर दीजिए.
Actually, Kegel exercises you don't have to use any instruments or any sort of physical therapy. It's mainly the exercises that the patient does herself at home. The Kegel exercises are mainly the contraction and relaxation of the pelvic floor muscles, which can be just taught to the patients on Skype by the physiotherapy people. And also when the patient comes to us, to any antenatal clinic, they always have the mothercraft classes in which we tell them how to do Kegel exercises after the deliveries also, so that they can have a pelvic floor muscles stronger, which usually becomes relaxed during the delivery time. So these Kegel exercises, they don't need any physical instruments or any guidance. Maybe just on a Skype, they can see the videos which are available on YouTube. They can see how to perform Kegel exercises themselves. It's their own way of doing it.
Okay, so the answer to that question would be जो डॉक्टर साहब ने आपको प्रिस्क्राइब की है मेडिसिन, आप उसको यूट्यूब पे देखें, उसको आप इंटरनेट पे देखें, और उसको फिर आप घर में ही प्रैक्टिस कर सकते हैं. आपको उसके लिए कोई स्पेशल इक्विपमेंट की या किसी जिम की जरूरत नहीं है, वो आपने घर पे ही ट्राई करनी है. Okay. Third question would be, as you mentioned about combination therapy for overactive bladder. In your experience and as per the literature, कितने पेशेंट्स होते हैं जो कि रिफ्रैक्टरी टू मोनोथेरेपी होते हैं, उनको कॉम्बिनेशन पे शिफ्ट करना पड़ता है, नंबर वन. और नंबर टू, जब वो पेशेंट शिफ्ट होते हैं तो उसमें क्लिनिकल सक्सेस रेट कितनी नजर आती है, खासतौर पे पाकिस्तानी पॉपुलेशन में.
Actually, we have only started using the second line drug, Merapigron, maybe about 2 to 3 years that we have been using this. In Pakistan, it was not available previously. So we were usually trying either the tetracytol and also the solifenacin. Both have the same mode of action, right? But slightly more superior is Solifen because it has less side effects compared to the tolterodine. So when initially we try to use monotherapy, okay? And about I think 50-60% of the patients respond to monotherapy, But as the time goes on, maybe after 2 to 3 years, it sometimes becomes ineffective, and then they say they are not getting as much benefit as they used to have previously. So in those cases which are refractory to monotherapy, or which have they do not want to take it because they have more side effects, so we give them try these alone, either mirabegron alone, and then they get much better. And then the third group of the patients are those who are refractory to single therapy. Either we have tried monotherapy in the form of sulfan, or if we have tried marabiga, but they still do not respond. Then in those cases, I think it's less than 25 to 30% of the cases which may require combination therapy. 60% of the patients do respond either to one drug or to the other drug. But these are 30 patients who are refractory and who do not respond. Then in these we try combination, in which we said 50 milligram mirabigon and then the 5 milligram solid. And then
Okay.
usually within first month we see the improvements. Within
Okay.
first month they come back and they have felt much better and more satisfied with the treatment.
Okay. So basically, you are saying those patients that were refractory to monotherapy, when they switched to combination therapy, they got clinical success within the first week or first month of the therapy.
The
That
first
is
month.
for the first one. That's really aspiring. मैम थर्ड क्वेश्चन I've got is क्योंकि अभी कोविड-19 के लिए कोई वैक्सीन या कोई मैनेजमेंट अप्रूव्ड हुई नहीं है, बट डॉक्टर्स जो हैं वो कॉमनली प्रिस्क्राइब मेडिकेशन यूज तो कर रहे हैं कोविड-19 के लिए. सो इज देयर एनी ड्रग टू ड्रग इंटरेक्शन विद मायरा बैकग्राउंड एंड सोलिफेनेसिन विद दोस मेडिकेशंस जो कि डॉक्टर प्रिस्क्राइब कर रहे हैं फॉर कोविड-19?
I saw the drug interaction. Usually now the drugs with mainly the treatment to COVID-19 these days is the drug which is only tried are chloroquine and hydroxychloroquine. There are no interaction with the hydroxychloroquine or chloroquine with mirabigon or with solifan. Right? The other drugs which are antiviral therapies which have been used, and one of the ivermectin, which is anti-protozoa drug, which has been used previously for Middle East respiratory distress syndrome. This COVID-19 is the SARS-2 syndrome, and that is also used. But there are not many trials for the MERS. Similarly, there are not many trials for this SARS-2 or COVID-19 that we have these days. But as far as the common drugs, which are mainly the paracetamol or fluids or the management of pneumonias, which is the final severe effect of the COVID-19 infection, they usually have no side effects or no drug interaction with the solifan or with mirabigon.
Okay, so the answer would be that mirabegron and solifenacin has no documented drug-to-drug interaction with possible management of COVID-19. Ma'am, thank you very much. Before we end this session, I would like your message for the patients or doctors that are watching you. आपका क्या पैगाम है उन डॉक्टर्स के लिए या मरीजों के लिए?
I think during this time, my main message is that if the patients are worried about their, if they are first-time patients, then they should contact their clinic, their family physician first, or to their gynecologist first, and then ask them advice on phone or on WhatsApp, right? And then they can be asked to do the simple measures like controlling their fluids or lifestyle modification and things. And then do not come to the clinic immediately if you have mild symptoms, unless it is bothering you or any drug which you are taking. If you have developed any new side effects of any drugs, then you have to come and report to the doctor. But try not to come to the clinics for trivial reasons. Similarly, the important investigations like urinary tract infection have to be excluded, and you can send the sample from home. You don't have to come to the hospital. Somebody can take the sample, so that we like to know, okay, why your drug which you are using is not effective. Maybe you have an associated infection. So you send the sample and discuss with the doctor, and you can also get the report and send that to your doctor on the social media, and then get the opinion. So my request to the patients is that unnecessary investigations can be avoided during this time. right? Unnecessary visits to the clinic should not be done unless you develop any severe side effect of the drug, or you are not getting benefit, or you have developed an associated thing which may be like urinary tract infection, which is more likely in patients. And
Okay.
another important thing is that if the fever can be due to COVID-19, and fever can be due to urinary tract infection. So in these cases, patients has to be very clear about the symptoms, because the main symptoms of the COVID-19 infections are dry mouth and then the fever of more than 38, right? But in cases of UTI, usually the infection is associated with nausea, vomiting, and usually it is associated with pain in the lumbar region or in the suprapubic region, just above uh, their pelvis. So if they have the pain associated with pain, then it can differentiate between these symptoms, because both join the same symptoms. फीवर है, अनवेल है, nausea है, vomiting है, ये दोनों problems में होता है. So patient have to differentiate that if there is any associated symptom, or if they are getting any burning micturition, or the fever is coming with rigors. That is another diagnostic feature of UTI and not of COVID-19.
Okay, so the message briefly is stay home, stay safe, और जो भी प्रॉब्लम है अपने फैमिली फिजिशियन के साथ सबसे पहले टेलीफोनिकली डिस्कस करें. अगर आपको यूटीआई को एक्सक्लूड करने के लिए टेस्ट भी करवाना पड़ता है तो वो घर से बैठ के भी सैंपल आप दे सकते हैं. और फीवर को आपने थोड़ा सा मॉनिटर इस तरह से करना है कि यूटीआई की वजह से है या कोविड-19 की वजह से है. With this message, Dr. Saiba, thank you very much for your valuable time और आपकी
The
deep
doctors, I
insight.
think, for the doctors, I think they have to use now more social media and teletherapy, advise the patients on phone or on WhatsApp, where
Exactly.
they can write the drugs, their dosage properly, because on phone there is a risk that the patient may take the wrong name of the tablet and may get side effects. So it is better to give them a written instructions regarding their therapy.
Exactly. There are many platforms जहाँ पे टेलीमेडिसिन की जा रही है और उसकी प्रिस्क्रिप्शन भी बकायदा पेशेंट से शेयर की जाती है to remove the chances of medication errors. With this message, thank you very much, Professor Haleema Hashmi, for your valuable time and deep insights about overactive bladder during COVID-19 era using telemedicine. Thank you, ma'am.